Welcome, and thank you for joining us today live on YouTube, and for our colleagues here from Fiji joining us here in Suva. My name is Kevin Kim, and I'm the Operations Analyst at the World Bank Group Korea office, and I will be your MC for today. Before we get started, I would like to mention that the chat function is live in the YouTube live stream, so please send in questions and comments about the presentations and the panel discussions, and we'll try to answer them to you live if time permits, or get back to you by email. Now, this webinar series was made possible through the generous support from the Ministry of Economy and Finance of the Republic of Korea, and it has been designed to gather knowledge and share experience of the East Asia Pacific region in responding to the COVID-19 pandemic. Our main objectives for this webinar series is to promote knowledge generation and exchange adaptation of international best practices in preparing for and responding to subsequent phases of COVID-19. We had our first and second webinar in April and June, in which we had invited experts from Korea, Mongolia, Malaysia, and Vietnam, who shared key findings from their respective country case studies. Today, we have our final webinar series, and we'll be focusing on the experiences of Fiji, as well as Korea, followed by a panel discussion by experts who will reflect on the lessons learned and how we can assist our client countries on effective methods to prepare and respond to future pandemics. The task team is also planning on organizing a regional COVID-19 preparedness and response forum in May of next year. For more information about the regional forum, we'll be sharing this with you early next year. Now, without further ado, I'd like to invite Dr. James Fong, Permanent Secretary for Health from the Ministry of Health and Medical Services of Fiji, to deliver the opening remarks. Dr. Fong, the floor is yours.
Representatives from the Korean Ministry of Economy, Professors Sunman Kwan and Taejin Lee from the School of Public Health Sciences at Seoul National University, Associate Dean Research, College of Medicine, Nursing and Health Services, Fiji National University, Professor Donald Wilson and team, the World Bank Korea Office Special Representative, Jason Alford, World Bank's EAP Practice Manager and Task Team Leader, Aparna Somanathan, Vikram Rajan and team. A big Mbola Binaka, and I'd like to welcome our distinguished speakers, panelists, and partners in health and online participants. Thank you for joining us today as we launch the webinar series on the World Bank Group Korea Partnership on COVID-19 Preparedness and Response, Lessons Learned from Fiji and Korea Case Studies. I also like to thank you very much for the invitation to be here today to review and compare how the two countries have prepared and responded to COVID-19. Also welcome this initiative of knowledge sharing on pandemic responses and lessons learned from across the East Asia Pacific region. COVID-19 is a health emergency. As a health emergency has reminded the global community on the need to strengthen our capacity to prevent, prepare, and respond to disease outbreaks. It has also highlighted the fragility of public health and healthcare delivery systems. Like other countries and regions, the pandemic has halted and possibly caused a backslide on our progress towards universal coverage, and therefore the journey towards achieving sustainable development goals. Beyond the classification of COVID-19 as a health emergency, this COVID-19 has also highlighted the important point that health is not an independent sector. The preparedness efforts, policy and legislative considerations, as well as the decisions around response strategies, required a cross-sectorial and whole-of-government approach. This will not be the last pandemic. Fiji, like other countries in the region, is also vulnerable to complex health and humanitarian emergencies, being front and center to natural disasters. And considering the region's high risk of climate emergencies, today's discussions will be quite valuable to us. I congratulate the presenters and the panelists for all your work. The past few years have changed the lives of many all over the world. It was a period of great stress on families, on systems, in health, education, production lines, supply chains. But there were also some innovations, like the enhanced connectivity that opens up the potential for serving patients and communities closer to their homes. In Fiji, we created a network of command centers in divisions and subdivisions that allow for better sharing of knowledge and best practices. It allows for the development of templates to track changes we agree upon to be made and ensures that the efforts we make has the impact that we want. In my own experience, M&E structures that health workers can relate to is key to avoiding the unfortunate fact that many documents on strategies and action plans hit shelves and stay there. As such, I look forward to the presentations, the publications, and the discussion today, especially on the lessons learned to better inform not only our pandemic preparedness plan, but also ensuring resilient, collaborative partnerships and health service delivery. Naka, thank you.
Thank you very much for your warm remarks, Dr. Fong. Now, without further ado, I'd like to welcome our first presenter, Dr. Nage Wanga, who is the head of the Pacific Research Center for the Prevention of Obesity and NCDs, which is a WHO collaborating center for obesity prevention and management, a first in the South Pacific that was inaugurated in 2019. Now, prior to this role, she has held numerous positions in research and is currently an associate professor at the College of Medicine, Nursing, and Health Science at the Fiji National University. Dr. Wanga, thank you for joining us. The floor is now yours.
Thank you very much. I'm honored to present the key findings from the Fiji case study on behalf of Dr. Donald Wilson, our Associate Dean Research and Director of the new Fiji Institute of Pacific Health Research at the College of Medicine, Nursing, and Health Sciences at the Fiji National University. Next slide, please. The flow of the presentation will be as follows. We'll discuss a bit on the epidemiology of COVID-19 in Fiji, a socioeconomic impact of COVID-19, a bit on preparedness, health systems response, and we'll discuss some lessons learned and challenges. Next, please. So firstly, let us look at the epidemiology of COVID-19 in Fiji from March 2020 to 30th June 2022. Next, please. So what happened between March 2020 to June 2022? Fiji recorded a total of 65,713 cases, with 7,000 cases per 100,000 population, and 864 deaths, with 3 deaths per 100,000 population. The country recorded 3 waves of COVID-19 during the period, as highlighted in green, blue, and gold points below. You will identify peak in cases and deaths from June to August of 2021 and January to February of 2022. The first wave hit Fiji from March 2020 to March 2021, with 67 cases recorded, or 7 cases per 100,000 population, and 3 deaths recorded, with 0.22 deaths per 100,000 population. And then the second wave was from April to December 2021, with 52,748 cases recorded, or 5,673 cases per 100,000 population, and 697 deaths recorded, or 75 deaths per 100,000 population, and a drop of cases and deaths recorded in the third wave. Next slide, please. So where are most of these cases and deaths occurred? To begin with, Fiji's first case and death were reported from the western division of Viti Levu. So there are 2 big islands in Fiji. Viti Levu is where our capital city of Suva is located. First case was a 27-year-old male returning from San Francisco, and first death was a 66-year-old man returning from India. Majority of Fiji's cases and deaths were reported from the central and western division of Fiji. Figure 2 presents a distribution of cases in each division, 67% from the central, 28% from the western, and at least from the eastern division, with 2%. Figure 3 presents a distribution of deaths by division, and so most of these deaths were reported from the central, in blue, followed by western division in orange. Next, please. Who were affected by COVID-19? So majority of the deaths were from older adults, who are more than 50 years of age. Elderly and patients with comorbidities were vulnerable to severe infection and deaths. Table 1 presents a summary of COVID-19 deaths in the first, second, and third wave. However, we were not able to obtain data from the 17th September 2021 and onwards due to the limited information of the decrease of the deceased cases as data were obtained through archival research. In the first and second wave, till September 16, 543 deaths were reported, with the youngest death being a 4-month-old male and the oldest death being a 102-year-old female. Majority of the deaths were reported from 50 years and above, and less deaths reported from 39 years and below. And 3 deaths reported were from children less than 1 year of age. And in the third wave, 165 deaths were reported. Majority of these deaths were reported from 50 years and above, and less deaths reported from 39 years and below. 6 deaths were reported from children at the age of 0 to 9. Table 2 presents a proportion of deaths by sex and division, so graphical presentation can be seen in the next slide. Next slide, please. Figure 4 presents a proportion of deaths in the first and second wave till September 16, 2021. And the graph shows that most deaths were reported from 60 to 69 years, which is 25.8%, followed by 70 to 79 years, 23%, and 80 to 89 years, 18%. Less deaths were reported from 20 to 29 years, 10 to 19 years, and 30 to 39 years of age. Age by sex, we can see that for both males and females, more deaths were reported from 60 to 69, 70 to 79, and 80 to 89 years age group. In the central division, most deaths were received from 60 to 69, 20%, followed by 70 to 79, which is 16%. Age category. In the Western Division, highest number of deaths were reported from 80 to 89 and 70 to 79, 7.4 and 6.3 respectively. So figure 5 presents the proportion of deaths from December 2021 to 30th June 2022 as third wave. Graph shows that most deaths were reported from 70 to 79, 30%, 80 to 89, 18%, and 60 to 69 age group with 21.2%. Fewer deaths were reported from 10 to 19, 20 to 29, and 30 to 39 age group. And by division, Western Division has the highest number of deaths, 40.6%, followed by Central Division, 38.8%, and the least from the Eastern Division and Northern. Next slide, please. So let's look at the socioeconomic impact of COVID-19. Next slide, please. And due to COVID-19, Fiji's GDP, gross domestic product, contracted by 15.4% in 2020 and 4.1% in 2021. However, it is expected to increase by 11.3% in 2022. COVID-19 has also affected businesses in the country, as lockdown measures have shortened business hours, temporary reduction of staff working hours, people losing their jobs, and few on work-from-home initiative. With business affected, employers had to renegotiate buildings rent, deferment of loan repayments, and reduction of wages and salaries of its employees. In inflation rates, country experienced low inflation rates in 2021 and 2022 as COVID-19 caused movement restrictions, labor shortages, high freight costs, and discrepancies in demand and supplies. With government debt, COVID-19 pandemic caused the Fiji government debt to surpass the accepted benchmark of 50%. Government had to support the economy, hence increased borrowings were done from domestic and external sources, such as the Asian Development Bank, the World Bank, JICA, Asian Infrastructure Investment Bank, DFED, and MFED. Remittances. There were been increased remittances experienced in 2021 as people in overseas had to support their families, relatives, and friends back home in Fiji. Next slide, please. Next, please. So in terms of preparedness and the organizational structure, for the overall COVID-19 response team, the Honorable Minister Prime Minister, chaired the country's COVID-19 response team. The Chief Medical Advisor chaired the COVID-19 task force, while the General Manager Incident Management Team chaired the COVID-19 response plan. In terms of economic recovery, governments established the COVID-19 risk mitigation team. Permanent Secretary of Economy chaired this working group. It worked closely with the Permanent Secretary Health, the Permanent Secretary from the Commerce, Trade, Tourism and Transport, and the Permanent Secretary from the Immigration Department. And one of the challenges experienced is the low dissemination of information from admin to clinicians level, example with the new SOPDs, gazetted directions, and so on. Next slide, please. So with preparedness, looking at legal framework, preparedness in terms of legal framework, the government convened cabinet at the Ministry of Health headquarters. This is to ensure the timely approval of cabinet papers, notices, restrictions, policies, and new regulations. One of the milestones achieved during this period was the commandment of the Public Health Management Infringes notices. So we can see the coordination of the team when this is been based at the Ministry of Health headquarters. So what were some of the gaps and challenges? Gaps: no policies or protocols were in place for quarantining people who refused treatment for infectious disease. And the challenges: legal system was not able to trace a few violators who broke the public health infringement notices, as they gave incorrect information detail to the enforcement and keep track on those who failed to pay the notice penalty. Next, please. Now we look at the health system. Next, please. So there are some good things coming from here. Contact tracing. Contact tracing is a very important component of Fiji's success in the detection and breaking the chains of COVID-19 transmission in the country. The country introduced the new Care Fiji app to support traditional contact tracing methods. However, there were a few challenges with this app. Few people could not download or install the app as they have incompatible devices. Few do not know how to use Android and iOS operating systems, especially the older generations, and few do not have enough storage capacity in their device, hence cannot install the app. With testing, the testing of COVID-19 began on 28th January 2020 with samples shipped to Australia. Testing began in Fiji on March 2020 and was initially done at the Fiji Center for Disease Control. Country has a total of 5 testing sites. Private labs also moved in to assist the Ministry of Health. Country also conducted 3 methods of testing: the rapid test, BioLine, the PCR test, and the Gene Expert test. During peak periods from June and July of 2020, the ministry conducted 3,000 to 4,000 tests per million population per day, more tests than New Zealand and the same as Australia in the same period. Next, please. With vaccination, AstraZeneca, Moderna, and Pfizer are the vaccines used in Fiji. The AstraZeneca and Moderna are the 2 main vaccines used, while Pfizer were deployed to children at the ages of 12 to 15 years. Table 4 presents the total number of people who received the first and second dose. As you can see in the table, with the 103% with dose 1 and 95% with dose 2 from the adults more than 18 years. And so to increase vaccine coverage in the country, government introduced the no job, no jab policy and offered incentives, cash assistance with $50, $90, and $180. However, people must be vaccinated in order to obtain this. The vaccine registry system was the system used for vaccination, and one of the challenges faced during the pandemic was the issue of the vax cards to people who were not vaccinated. One of the establishments was the introduction of the drive-through vaccination drive-in, as people were vaccinated in the comfort of their vehicles. And so Table 5 presents the soft or app used during the pandemic, as you can see on your right. So swabbing, it is really to track and analyze people who have successfully been swabbed with the use of Tamanu, and the surveillance of incoming travelers if they display COVID-19 with the use of somas to track and monitor health status of incoming travelers who were quarantined, and the tracking activities in medical facilities used Tupaya and Meditrack to update and track activities in different medical facilities. Next, please. Now we look at the service delivery. What were some of the health responses during the pandemic? So, to ensure that health services were not disrupted, the healthcare workers were grouped into working bubbles. Government established the Border Health Control Unit, and the health centers and nursing stations were used as screening facilities. The healthcare workers worked with village healthmen, known as Turangani Koro, to conduct health promotion and to identify cases. So the engagement process here really worked well. The schools, community and village halls and hotels were used as quarantine facilities, so there's a lot of coordination between government and non-government organizations as well as business industries. And the CWM, or Colonial War Memorial Hospital and Lautaka Hospital, were converted into a COVID-19 care facilities. And the Ministry of Health established a mobile swabbing team to reach primary and secondary index case. So a toll-free line was developed, 165, so that patients can access doctors and nurses using virtual care or telehealth. And some of the establishment included the establishment of the DFAT, of the FEMAT to treat cases that hospitals would normally treat, or a field hospital, the establishment of the pre-hospital emergency coordination care, which is an ambulance transfer and retrieval services, establishment of the oxygen body that looks at restocking oxygen in the morning and the afternoon, and lastly is the commandment of the COVID-19 engagement of private medical general practitioner scheme. 17 GPS were engaged in this scheme. And some assistance received from the Ministry of Health in terms of human resources. Non-health ministries offered their helping hand, for example, Ministry of Education, military, Navy, and police, and many others who volunteered to support. Australia and New Zealand sent in their medical assistance team, and thanks for these two countries. And of course, retired health personnel, volunteers, and civil society organizations assisted the ministry in their response to COVID-19. Next, please. So we look at risk communication, the health system's response in terms of risk communication. The Honorable Prime Minister, Minister for Health, and the Permanent Secretary of Health conducted daily COVID-19 briefings and updates, and this is something the community look forward to. The social media platforms such as Facebook and Twitter were used to get information to the public. Panel discussions were conducted between health experts in Fiji, mainly of doctors at the Ministry of Health, health staffs at the Fiji National University, in specific the College of Medicine, Nursing and Health Sciences, and health experts overseas. Discussions were done in English, Hindi, and in the Itoke language. One of the challenges faced was the spreading of misinformation of the COVID-19 virus and the vaccines used in the country. And this was one of the challenges that we tried our best to mitigate. Next slide, please. So we look at the COVID-19 impact on universal health coverage and sustainability. So Fiji's universal health coverage with index stands at 61 in 2019, with reproductive, maternal, neonatal, and child health being the highest, followed by infectious disease, services capacity and access, and the least from the non-communicable diseases. And comparing universal health coverage in the Pacific Island countries, Fiji scored the highest with 61 points, followed by Tonga, Samoa, and the least from Papua New Guinea. The impact of COVID-19 on universal health coverage: few people were not able to access to health services due to the restrictions of public services vehicle because of the enforcement of lockdown and the establishment of containment areas. There were lack of health specialists, professionally in the hospitals due to sickness, or were out in the field with COVID-19 response team. Few medical procedures was suspended due to the risk of transmitting COVID-19 viruses. Next, please. So lessons learned, we'll look at two slides on lessons learned and the last one on challenges. Next, please. So we'll look at lessons learned from containment and mitigation. With containment, early activation of the FEMAT was critical to ensure continuum of health services delivery during the pandemic. Early formation of the instant management team was important for the coordination of the whole of government response. And early closure of borders and strict implementation of border control measures helped keep the COVID-19 virus out of the country. And intensive testing, contact tracing, and timely treatment is important to prevent further spread of infection. The role of the Fiji CDC, or Center for Disease Control, in facilitating good testing capacity led to the early detection of cases, which prevented the direct transmission of the virus to the community, especially during the first wave. And the establishment of the Border Health Protection Unit was critical in the response to the pandemic. Publicizing of cases using spot maps was critical in informing people on the location of cases and to prevent the spread of the virus. In mitigation, the government's varied vaccination locations enabled the successful vaccination of more than 90% of Fiji's population. The ICT applied to track COVID-19 infections and vaccine uptake in real time is useful to inform decision making. Establishment of the pre-hospital coordination care center and the Ministry of Health Oxygen Unit were critical during the pandemic. Aggressive risk communication during the second wave was conducted to combat vaccine hesitancy, and retaining the trust of community, institutions, and leaders, especially religious leaders and healthcare professionals, are pivotal towards the government's success in combating COVID-19. Lastly, the use of incentive has been effective in boosting vaccination coverage in Fiji. Next, please. Continue with the lessons learned. The whole of government approach involving stakeholders from government, private sectors, as well as local and infection and international non-government organizations are important tools for the fight against COVID-19. The Fiji's healthcare system allowed everyone to access health services for free without any burden during the pandemic. Utilization of technology enabled last and efficient track of data collation, analysis, and dissemination. And there is continuous capacity development at the institutional, legislative, and individual levels, which was very critical for the overall understanding of the preparedness and mitigation process to ensure trust. Good leadership was a prominent factor in the fight against COVID-19 in Fiji, and full support from the bilateral partner countries, technical agencies, the private organizations, and non-government organizations and communities enabled the ministry to function effectively during the pandemic. And government involved international academic institutions and technical agencies to assist and inform the country of the protocols were good to take during the pandemic. And the arrival and contribution of the OSMET and New Zealand AMET teams boosted morale and services delivery. Decentralization of workshop has enabled health workers to battle through the containment and mitigation phases of the COVID-19 pandemic. The existence of the toll-free helplines was critical during the pandemic. And lastly, the strengthening of Fiji's legal system was able to address prominent issues during the pandemics, the no job, no jab policy, and the public health infringement notice. And the last slide, please. So the challenges. Misinformation was really a challenge. The government and the Ministry of Health to develop and adapt a messaging framework to counter misinformation. A lot of resources were used in this area. The burnout and stress among healthcare workers, so there was psychological support through individual or group counseling and training is critical to provide respite and continually motivate healthcare professionals. The vaccine hesitancy. Conducting awareness programs is critical in the case of an outbreak, and more research is needed to determine cause of vaccine hesitancy among healthcare workers in Fiji. The financial burden of quarantining returning Fiji citizens. Again, the government to plan and develop management systems on quarantining returning Fiji citizens and healthcare workers during a health crisis. Social gathering, which is the traditional and cultural, very important in our traditional culture. The challenge in terms of enforcing non-pharmaceutical intervention. And lastly, the insufficient digital literacy online capacity training to be conducted to healthcare workers and other non-health ministries. So we are hoping that these challenges will be addressed should there be another wave, a bigger wave that will come into Fiji. And ladies and gentlemen, that's the last slide from today's presentation. Thank you very much. Vinaka.
Thank you, Dr. Wanga. Now, I would like to introduce our second presenter, who is joining us online from Korea. Dr. Taejin Lee is a professor of health economics at the Seoul National University Graduate School of Public Health. His research area includes economic analysis of healthcare systems, especially focusing on health financing and financial protection, as well as economic evaluation of various interventions in the healthcare sector. He has served as an advisor to the Korean government health policy and is currently a member of the Pharmaceutical Benefit Advisory Committee for the Korean Ministry of Health and Welfare. Dr. Lee, thank you for joining us. The floor is now yours.
Okay, thank you, Kevin, for nice introduction. And good morning, everyone. And thank you for inviting me to this excellent webinar. I am delighted to have an opportunity to share Korea's experience with the preparedness and response to COVID-19. Okay, can you see my slides? No problem.
Yes,
okay,
we can see the slides.
Yeah, thank you. This slide shows the table of contents of the country case study, and my presentation will follow the order of this table of contents. Okay, let me briefly summarize the epidemiology of COVID-19 with some important government measures. The first COVID-19 case in South Korea was confirmed on January 20, 2020. And due to the local outbreak in Daegu and Gyeongbuk region in February, the number of daily confirmed cases rapidly increased, exceeding 10 per million people. During this period, the government announced the social distancing policy instead of a draconian lockdown. In the early stage of the outbreak, the stringent government measures including social distancing policy, was successful in reducing the number of new confirmed cases and deaths. However, the number of the daily confirmed cases has continued to increase throughout the year. And considering the increase in vaccination, which started in February 2021, government decided to implement a gradual return to normal strategy from November the 1st last year, although the number of daily confirmed cases increased to 50 per million people in October. The outbreak of the Omicron variant started in the spring of this year and dwarfed the previous waves, with the number of daily confirmed cases reaching almost 8,000 per million people in March 2022, which is the world record, I think. And the number of daily confirmed cases was still as large as 2,500 per million people in August this year. And this graph shows the cumulative confirmed COVID-19 cases per million people and cumulative deaths per million people among a few countries. And the Omicron variant triggered the surge in COVID-19 cases in South Korea in March this year. And as of August 2022, cumulative confirmed cases per million were 441,000 in South Korea, compared to 76,000 on world average. However, the total deaths per million were 511 in South Korea, lower than the world average 820. So the case fatality rate is relatively low in South Korea compared to the world average. Okay, now socioeconomic impact of COVID-19. The social distancing policy instead of draconian lockdown mandates, enabled continuous production activities and business cycle with support of relief funds. Like other advanced countries, the Korean government's fiscal policy has kept an expansionary stance to cushion the effects of the pandemic on economy. The Korea's economic contraction was smaller than that of in most OECD countries, with real GDP declining by 1% in 2020. So economic activity, particularly the exports of high-tech products, recovered shortly after the second quarter of 2020. As you can see here, in gray line, the export of high-tech product recovered shortly after the second quarter of 2020. However, the private consumption shown in the red dotted line continued to struggle across the year. So, therefore, to boost consumption, emergency disaster relief funds and customized economic supports have been provided several times since the outbreak of the pandemic. And with substantial COVID-19 response measures, the overall fiscal deficit for 2020 widened to an estimated 4.1% of GDP. Now turning to preparedness. Korea's national infectious disease risk alert system has 4 levels of crisis alert. The level 4, the serious level of the national infectious disease crisis was declared on February 23rd, 2020. And figure 5, this figure shows the response system of Korean government when the level of alert is highest in red. We have a Central Disaster and Safety Countermeasure headquarters, which was headed by the Prime Minister, and this headquarters makes the final decision. And while the Korean Disease Control and Prevention Agency, in short KDCA, the former Korean KCDC, provides key technical information to those decisions. And legal framework and policy measures. Korea has the Infectious Disease Control and Prevention Act. In short, I call it IDCPA, which is the primary law to prevent, respond to, monitor, and evaluate infectious diseases in Korea. And the IDCPA has designated specific roles and responsibilities to government bodies since the MERS outbreak in 2015. And the IDCPA law was updated several times during the COVID-19 pandemic to facilitate the flexible response and systematic adjustment, including data collection from various sources and information disclosed to the public. And health system. And Korea has national health insurance, which is the main financing mechanism for healthcare. And there was no financial burden on patients for the test and treatment of COVID-19, as they are exempt from cost sharing for communicable diseases, which the government is mandated to fund. And mainly because of the opposition of the Korean Medical Association. And however, telemedicine was temporarily allowed to improve access to care and reduce potential cross-infection during the outpatient visit. And telemedicine service has been covered by the NHI with an additional fee. And turning to response in terms of testing, tracing, treating, and vaccinating. Korea has relied heavily on extensive and rapid testing and contact tracing, combined with social distancing from the beginning of the pandemic. And more than 600 COVID-19 test centers were established in public health centers and hospitals. And once a patient tests positive for COVID-19, epidemic intelligence service officers from the KDCA or health authorities conducted epidemiological investigation conducted to trace the source of the infection, with all routes traced to identify when and where the patient visited. And in contrast to the rapid testing and contact tracing, Korea was rather lagging in vaccination, which started in late February 2021. And it was delayed due to intermittent shortage of vaccine supply because of late contract with vaccine manufacturers in an early stage of the vaccine rollout. And despite the delayed start of vaccination, as of August 2022, 86% of people in South Korea were fully vaccinated, and 78% had the booster shot. And due to the vaccination strategy that prioritized the protection of high-risk groups and the social distancing policy based on the testing and tracing, and South Korea has been able to minimize the demand for intensive care, infection transmission, and death toll. And patient triage and service delivery. During the pandemic, it is very important to reduce the burden on health systems capacity, which is closely related to mortality. So facing a rapid increase in confirmed case, on March 1st, 2020, the government published a guideline to classify confirmed cases into 4 categories: mild, moderate, severe, and very severe. So the moderate to very severe patients were hospitalized, while the mild patients were monitored in living treatment centers. Medical providers stayed at living treatment centers and checked vital signs twice a day to transfer patients to hospitals if their symptoms worsened. The patient classification system with living treatment centers was able to alleviate the burden on acute hospitals during the pandemic crisis to a great extent. Recently, most the living treatment centers are not in operation, and patients with mild symptoms are encouraged to have home treatment. Risk communication. And since January 2020, Korean central and local governments have taken various measures to disclose real-time information to alert individuals to a risk of viral transmission, as well as inform them how to reduce the risk. 3 types of information have been disseminated to the public on a daily basis. The first one is diagnostic information to inform citizens of current status of COVID-19, which includes daily and cumulative numbers of newly tested, diagnosed, expired persons, and so on. The second one is prognostic information to deliver how to reduce the possibility of infection transmission and negative consequences, which include detailed information of how to get COVID-19 tests, treatments, and vaccination, and so on. The last one is policy-related information to encourage civil participation and protect affected or vulnerable population, which include levels and rules of social distancing measures and related recommendations. Now, information and communication technologies, ICTs. An integrated ICT-based network centered on KCDC, now it's called KDCA, was developed to establish a real-time information sharing system. We have a long list of ICTs applied to contact tracing, including self-diagnosis mobile application, and so on. Another example of using ICTs is a public mask purchasing system, which was implemented through the drug utilization review system of the NHI, which gave an on-the-spot information on one's purchasing history at any pharmacy. It contributed greatly to controlling the demand for masks when there was a shortage of supply. And another example of innovation is drive-through system, which was introduced to manage the risk of cross-infection. In the case operated by Seoul Metropolitan Government, it was known that up to 1,000 people can be tested a day. Okay, social protection and disaster relief funds. The prolonged COVID-19 pandemic worsened the economic situation of many households and small businesses. So as shown in this table, disaster relief funds were provided several times to protect the most economically afflicted members of the society. The first relief funds were organized for the entire population, while the latter ones were targeted to certain businesses and occupations or vulnerable population, especially small businesses and insecure workers. And in addition to these nationwide disaster relief funds, many municipalities have provided disaster relief funds on their own, depending on their financial situation. And COVID-19 and universal health coverage. This figure shows the overall improvement of the UHC service coverage index in South Korea and other countries in the East Asia and Pacific region between 2000 and 2019. Here is Korea and here is Fiji. And the next slide shows the impact of COVID-19 on health expenditure of the NHI in 2020 by type of medical institutions and by Department of Ambulatory Services. The increased rate of the expenditure in 2020, which is shown in yellow line, was much lower than the average growth rate over the previous decade, shown in gray line. The impact varied depending on the clinical department, showing sharp decrease in the utilization of pediatrics and ENT services by about 35% and 20% respectively, and a large increase in the utilization of psychiatry by 19%. So, on the other hand, the decrease in medical use does not necessarily mean a decrease in the quality of medical services or the level of population health in Korea. This may be particularly true of Korea, where the average number of outpatient visits was as high as over 18 cases per person per year. So it is necessary to find out whether a significant decrease in medical use in some patient groups during the pandemic has actually had negative effects on their health. Okay, turning to lessons learned. There are some best practices I can share with you. A centralized control tower and coordination system between central and local governments were prepared from the previous experiences. At the time of the MERS outbreak in 2015, the Korean government was criticized for poor coordination between central and local governments and poor information disclosure. Since then, the Korean government had paid much attention to have legal framework and organizational structure ready for the next outbreak of the infectious diseases. And the second one is the rapid response should be supported by the revisability of the legal framework. For example, facing the criticism on privacy issues, the Korea had the IDCPA law revised immediately to reduce the scope of the information disclosure while maintaining some essential information for contact tracing. And next one is ICT innovation, which contributed to alleviating the burden on testing and tracing, operating living treatment centers, and supplies procurement. And the last one is the patient classification system, along with the designation of living treatment centers, which helped tremendously to reduce the burden on hospital facilities. Providing essential services for non-COVID-19 patients has been sustained without the health system being overloaded with COVID-19 patients. And some challenges. Infodemic, which I think information epidemic, has put the policy measures at the risk of public mistrust and miscommunication. At an early stage of the vaccination, its side effects were exaggerated by some media and politicians to a great extent. So it is imperative to restore the public's trust in the media to efficiently manage the pandemic. The prolonged pandemic revealed some shortages of healthcare workers in Korea. And even if the number of beds for COVID-19 patients is sufficient, it is argued that not all of them may be immediately operated, mainly because of lack of health professionals. So to make the crisis response system sustainable, it is necessary to recruit and retain enough health manpower to avoid their burnout and to ensure their efforts compensated properly and timely. And the last point is that balance between the level of social distancing and disruption of economy, education, and well-being should have been sought as early as possible to minimize the unequal socioeconomic costs in addition to saving more lives. Stringency of social distancing could save lives of patients, but must be accompanied by enormous socioeconomic costs. For example, it may have indirect negative effects on the health of the population through reduced income. So it is necessary to find out an optimal level of social distancing, not only to save as much lives as possible, but also to ensure livelihood of the citizens. Okay. Thank you for your attention.
Many thanks to both presenters for their informative and very detailed presentations on each of the nation's COVID-19 preparedness and response. Now we're going to move on to the panel discussion. And I would like to welcome Margareta Herod, who will be moderating the discussions for today. Margareta is a senior health specialist for the World Bank Health, Nutrition, and Population Global Practice, stationed in Fiji. She has led large regional and multi-sectoral World Bank operations in different regions that fostered knowledge sharing and peer learning at the highest levels of decision-making and among implementers with a view to improve implementing results, particularly among hard-to-reach segments of the population, and to contribute to the global evidence base. Margareta, the mic is now yours.
Thank you very much, Kevin. And thank you for all the distinguished panelists and speakers today. It's been truly interesting to listen to the case studies that have been documented in Fiji and Korea, and I know in several other countries as well. I first just want to remind the audience that this is a live session, and we will be taking questions from the chat in case you want to put them there, and we'll try to address them live if time permits. Otherwise, we will respond following the closure of the session. I will now turn to two panelists who will be reflecting on some of the key lessons that have come out from this effort. We have Dr. Vikram Rajan, who is a task team leader at the World Bank, senior health specialist in health, nutrition and population, working on health system strengthening efforts and universal health coverage in several different countries across the East Asia Pacific region. And we also have Dr. Sonman Kwon, who is the former president of Korea Health Industry Development Institute and the former dean of the School of Public Health at Seoul National University, where he has been serving as a professor. Welcome to you both. Just checking, Dr. Kwon, that you are also connected.
Yes, I am.
Wonderful. I will start with you, Vikram. Your expertise focusing on health system strengthening, and I think you noted during the presentations the many parallels between the COVID response efforts and universal health coverage objectives that have been set out by governments across East Asia and the Pacific. Now, you have been leading a lot of these knowledge-sharing efforts as part of our role as a global knowledge bank. And my question to you is twofold. One is, what are some of the key lessons that you take away from the insights that have been presented, but also in terms of the value of peer dialogue and taking time to reflect on this period, which was truly dramatic across the world and that required very rapid responses in a changing context. Vikram, over to you.
Thank you, Margaret, and thank you to our speakers for their excellent presentation today. Also thank you to Dr. Wong for being able to attend despite his pressing engagements, and thank you the audience as well. No, that's, I think, two excellent set of questions, Margaret, and as we're in the third year of our pandemic, and as we now start to think about, moving forward, we start reflecting on the, sort of commonalities that have emerged in, through these case studies on, both pandemic preparedness and response, as well as
Okay, apparently my mic was not on, so clearly I'm getting back into hybrid mode. So if I can hear my own voice, I think everybody, is hearing me. So apologies for that. And so, just coming back to, the commonalities between pandemic preparedness and response and, universal health coverage. I think as we go to the rich case studies that have been, prepared, there are several lessons, but I'll probably reflect on a few of them today. I think the first one I would like to, sort of place on the table is governance matters. As we learned from, the Fiji case study, they took a whole of government approach towards, pandemic preparedness and response for COVID. And I think this is also very important for universal health coverage. Nutrition, non-communicable disease, and many other such health system challenges will need a whole of government approach. I think in Korea, what we saw was that the adaptation of the health system, driven by governance. So learning from the, MERS epidemic in 2015, they changed, some of their laws, they upgraded their agency. They also have, amended their national health insurance scheme to be able to, respond better. And I think it's similar the case for, universal health coverage and other health system challenges. I think the second one, which I would like to highlight that came out was the whole infodemic and the risk communication and the ability to engage with, communities. And we are also in a digital world. So almost which every country, in addition to Korea and Fiji, whom we look at, that seems to be one of the biggest challenges they faced during the pandemic. And so how do we respond to that, through having effective risk communication being able to engage with populations, as well as, get into this new world of social media, which honestly, I think we in public health are lagging a bit. But that's really where I think both for UHC and PPR, pandemic preparedness and response, that we need to really, begin to focus upon. I think the third one that I think the COVID pandemic almost reminded us again of the need to protect the vulnerable. I think the pandemic showed the deepened inequities already prevalent in our health system. In this case, yes, the elderly. In many countries, it was the poor, the migrant workers. I was hearing, Dr. Fong, but also from Korea, we've discussed this. So effects of climate change. So, all of these are again very relevant to, universal health coverage. So I would say, that again, the reminder that we need to focus on the issue of equity, but, widening and protecting the vulnerable, and what would that mean in different contexts. The fourth one, sort of moving to, I think, a more sort of, I think, a positive development that's taken place during COVID is the use of, I think, ICT and innovation. Almost many countries across, but then we saw the Fiji Care app, we saw the multiple use of, ICT, in South Korea, but many countries have, sort of used this, to sort of move forward. Specifically also, in Korea, I part of the case study, they actually used it to, begin telemedicine, which was actually not allowed in Korea prior to the pandemic. So I think that's something that's actually come out, which is very positive. I think something which can move forward. There are several other lessons, but I think that I would just like to end with saying, that, again, the sort of the linkages between communicable disease and non-communicable diseases again being brought out in COVID. So the people who were comorbid, conditions on, non-communicable disease, were more vulnerable to COVID, and vice versa. We see that now there's emerging evidence that they may actually, may have deepened or, worsened certain comorbidities in patients with, NCDs. So I think, again, when we think of universal health coverage, and I think it was mentioned a little earlier today, we should not be thinking vertically, but much more, again, from the broader UHC, health system lens. So I think that's on your first part. I tend to be a bit verbose, so kindly bear with me. And I think the second one, I think just through the process of developing this, I think the peer learning experience, I think, has been great. I think we worked with all, institutions from the 5 countries or individuals who were very much part of the response embedded in the institutions. So this was very much a country-led, knowledge learning and knowledge sharing exercise. We all came together to develop the framework, which took a health systems perspective towards it. We also had regular check-in points where we, actually shared, knowledge. And I think perhaps this is something to consider as a method, not just, again, I would say for COVID, but hopefully for, areas, whether it be on UHC or non-communicable disease. I think this kind of partnership, would help, us, try to figure out these complex problems around UHC and health systems. So I'll just stop there, Margaret. Back over to you.
Wonderful. Thank you, Vikram. And maybe just to add also the exhaustion of the healthcare workers who were really at the front line throughout the pandemic and need to continue to provide care to all in all types of settings. Dr. Kwan, over to you. Dr. Lee presented very well lessons, both positive and some very challenging issues faced during the pandemic. Would you also share your perspective, specifically perhaps looking at some of those lessons?
Okay, thank you. I want to provide a few comments, both from lessons from Korea and some some also valuable policy lessons for other countries. We all agree that preparedness is very important, but facing still a uncertainty from a pandemics or new pandemics, preparedness alone is not enough. I think we need to build some kind of agility in our response system or agility in our policy-making capacity, such that we should be ready to change and adjust our policy based on more new evidences and based on the experience of the previous response or preparedness. So I think we need to work harder to build a overall capacity or governance system that can more rapidly adjust to a new environment. In that sense, governance, and as Vikram also mentioned, governance is one of the key pillars that we should pay more attention. I mean, governance, I'm talking about the coordination between central, local government, coordination between public and private, and coordination between health and non-health sectors, because basically this COVID-19 pandemic is not really health issues. It's more a social disaster. So we need a broader socioeconomic capacity and readiness to respond to this COVID-19 pandemic. From a Korean experience, as Dr. Lee mentioned, Korea relied a lot on social distancing rather than a very rigid lockdowns. So it definitely has positive impacts, but at the same time, we need to pay attention to the social cost related with this social distancing. So in that sense, I think in many countries, including Korea, there is a tension between infectious disease specialists and those with more broader policy views, such that, as I mentioned, pandemic is not simply a health issue. It's more of a broader social disaster. So we need a good communication among experts in different specialties. And also we need a good kind of a policy-making or deliberation process, taking into account the perspectives of people in different sectors. So what I'm saying is that when we focus only on the impact of social distancing on the number of infected cases, we might be underestimate the cost of social distancing, because when we have a very strict social distancing, it has a huge negative impact on the education and welfare and the economic well-being of the vulnerable population. Previous presenters and panelists already mentioned the importance of equity, and I'd like to reiterate that we need to pay more attention to the vulnerable population, not only the older people, but also from the perspective of socioeconomic vulnerability. So daily workers, for example, and also immigrant workers, they are heavily hit by this COVID-19 pandemic. So in order to build a more resilient system for the future, we should pay more attention to these equity issues. Private providers, during this COVID-19 pandemic, public providers alone cannot effectively handle all those cases. So we need a good system how to incorporate the private providers into the system. In Korea, we have a huge predominant number of private providers. The majority of the healthcare providers are in the private sector. And to some extent, we succeeded in mobilizing private providers, but it is still, I think, it's a headache and a splendid failure in mobilizing the private providers. So, private providers have a lot of advantages in terms of efficiency, productivity in ordinary times. but we learned that the private providers showed a very high level of weaknesses, and they were very reluctant to contribute to the response to the COVID-19. So how to work with these private providers was, I think, another challenge for the future. And I also like to emphasize the community level resilience. I think we need a good macro level government policy, but we also need a community level resilience system as an effective response, or also the preparedness for the COVID-19 pandemic. And related to that is issues of primary care. In Korea, we had large hospitals. They played a key role in the response to COVID-19. But I think that what would be more cost-effective response? I think that we need to strengthen primary care. This is like a textbook story, but I think COVID-19 pandemic gave us an opportunity to rethink about how valuable the primary care is. So as I mentioned, if Korea has a better functioning primary care system, we would respond to COVID-19 in a more cost-effective way. I think the very weak primary care is an issue in the whole region. So I think COVID-19 gave us an opportunity to rethink about the role of primary care. Thank you.
Thank you, Dr. Kwon. Indeed, very, very wise words about both the preparation but also the agility in being able to act in the case of an emergency. Dr. Fong, I turn back to you. We've heard from the presenters and from the panelists the documentation of these experiences in 5 countries across East Asia and Pacific, including Fiji. But there's also a very specific context in the Pacific and value of sharing lessons across small island nations on issues of agility and preparedness. Would you like to reflect very briefly on some of the impressions that you've seen from this exchange and what we could potentially also take onwards to the Pacific community as we look forward?
Yes, thank you for that, Margarita. I agree. I agree with all the sentiments that have been expressed during this discussion. I guess the bit that I do always have a bit of concern about is how a lot of these knowledge and best practices are contextualized to small island country health systems. There is also some level of ability that needs to be created for some of our smaller island countries to be able to explore the ideas and the best practices more intelligently and contextualize them better. One of the key things that happened during the COVID-19 pandemic in Fiji was that we went about creating command centers in all our various subdivisions and divisions. And the whole idea was that we wanted to ensure that all the knowledge and best practices that were shared was being explored extensively by functional units out in the periphery. And they were able to put in their own interpretations of how they want to implement their initiatives and their responses, taking into account the limitations that they have. It was a way of trying to ensure that none of our responses were overly prescriptive. And I think one of the things that we have pushed on moving forward is to ensure that we have these command center setups, where at the moment we have a national senior managers meeting 2 times a week, discussing all the initiatives that we want done, and all the divisions then talk to their various subdivision command centers, and they keep sharing knowledge and best practices that are suitable for them. I also think that works well in terms of agility creation. It allows us to learn back and forth from both centrally and at the peripheral groups. And I think the key to all that is creating that kind of communication network And for many Pacific Island countries, the communication network just requires the ability to talk to each other more than anything else, whether it is virtually or face-to-face. And sometimes and having the ability to create some tracking templates that allow us to keep, to focus the agenda of our meetings, to be able to actually come up with action plans that are actually useful for the context that they're serving in. So I think that's basically, my line of thought, just reflecting on the discussions that we're having at the moment. Thank you.
Thank you, Dr. Fong. Yes, I think we will be looking at this lessons from the pandemic for many years going forward, and hopefully using some of the innovations to inform and enhance system strengthening efforts. I did want to mention there was a question from the audience to the panelists, and I invite you to respond, perhaps all of you. It's your thoughts on how to deal with health workers' burden and a way forward for the clinicians, and then future plans for leveraging the experience from this COVID pandemic. Perhaps we start with you, Dr. Kwan, and then followed by you, Vikram. And I do want to acknowledge also that we do have the Chief Medical Advisor from Fiji here in case, Dr. Jamesa, you would like to respond as well. Not putting you on the spot at all, but Dr. Kwan, please.
Actually, I don't have a very clear answer to that question, because it was a tough challenge for almost all healthcare systems during this COVID-19 pandemic. So we have limited resources. In the case of Korea, we always face a doctor shortages. But when government wants to increase the number of doctors, there is a clear opposition from the Korea Medical Association. Even during this COVID-19 pandemic, because of these shortage issues, government proposed to increase the number of doctors supply, and the KMA threatens to have a nationwide strikes. But more important issue in the case of Korea is probably during this pandemic, we have a huge issue of nurse shortages. So government responded by increasing the compensation for those nurses who are working in the intensive care units, things like that. And also government used some voluntary participation campaigns, such that because in the area of nurses, there are many nurses who have license but are not active in the labor market. So government used this campaign plus additional compensation to mobilize for the short time during this COVID-19 pandemic for those nurses who are not active currently in the market, but temporarily join the workforce during this COVID-19. But as I mentioned, this is one of the toughest issues that we need all think about it more seriously. Over.
Thank you, Dr. Kwan. Vikram?
Thank you, Margaret, and thank you for that question. I think, as you were also mentioning, I think it's one of the most important, including, burnout and stress for, healthcare workers during the pandemic, the frontline workers especially. So I don't think there are any easy solutions to it. I just wanted to make, a couple of comments. If a country like South Korea, whose human resources are much better than many other countries in the world, have also seen this, and it's been across many countries. I think we always reflect upon human resource shortages, in our UHC problem. So I think it's time that we need to start, again, thinking about what it mean, how do you deal with, task sharing? How do you deal with surges when it happens? And, part of it, I think Dr. Kwan already mentioned, compensation helps, but I think also huge psychological stress. So I think there was finally, I think in some countries where they began, I think, psychological counseling as well for, for healthcare workers. again, there is no easy fix for this, and that's why I still think that we need to sort of focus a bit from the UHC perspective, thinking about surges when it happens, how do you mobilize that, and human resource as a key element of UHC or health systems needs to be sort of looked into it. So I think that's sort of the second comment. And I think the third thing was that let's also not forget very early on, I think there was a lot of fear from COVID-19, in the early days of the pandemic, and there was a lot of stigma associated with with frontline workers. So many people, I mean, the same people who were serving you, like so in in countries like many countries actually, when they used to come back, to their houses, to their apartments, and then instead of actually being welcomed as heroes, were actually being, stigmatized against, saying, you're probably going to bring this back to us. So these are, I think, complex, issues that, in addition to, I think, quantity and surge, I think the need for, I think a better, I think communication strategy to reduce the stigma, as many people will acknowledge is not the last pandemic, I think needs to be addressed.
Thank you. Thank you, Vikram. And this, of course, in the context of contracting economies following the pandemic. And so very tough challenges. Dr. Jamesa, would you like to also make a comment?
Thank you, Margarita. Just a few comments. On the earlier question, I just wanted to add that, from Fiji's experience, we, in addition to dealing with COVID-19 outbreak, also dealt with multiple tropical cyclones. So, the challenges we face with multiple threats that we faced during the COVID outbreak. So with the cyclone came outbreaks of climate-sensitive diseases. So these were additional threats that we were dealing with. And so we needed to come up with solution and mitigating factors on how do you mount a disaster response in the face of a disease outbreak. So those are some of the challenges that we face, and I agree with the comment on in the preparedness phase to ensure that we have a comprehensive plan that is able not only to deal with the disease outbreaks, but also dealing with multiple threats that you face as you respond to diseases. And the second bit is totally agreeing that NCD is a risk factor and adds to the population or the vulnerable population that you have to look after when you're responding to an outbreak. So in Pacific Island counties and in seeds where NCDs are quite high, then our vulnerable population is a lot bigger, and for us to prepare for and have a target for. For health workers' loss or attrition, it is indeed a huge challenge. And for small countries like Fiji, it is the delayed second wave of impact of COVID-19 that we are now facing, where our health workers, but also workers in other related fields are being lost as they move to other countries. And we will have to come up with mitigation strategies to deal with this, and this may include increasing training, local training of healthcare workers, look at options of task shifting and task sharing amongst healthcare workers, so we have a bigger pool of people that are delivering healthcare services. This is certainly our current challenge, and we will have to come up with solutions and strategies that that will deal with the current loss, whether it's leaving the country or just leaving the servers or been affected by the response of the disease or breakthrough, mental health conditions that have been mentioned. Thank you.
Thank you, Dr. de Mesa. I trust we are running a little bit short on time, so I will wish to thank all of the presenters as well as the panelists online and here in the room. I would like to turn this over to Aparna, my colleague who is, I think, joining us from Vietnam today. She is always traveling. But Aparna, are you with us for some voice?
I am, and can you hear me?
Excellent. Over to you.
Thank you. Thank you, Margareta. Thank you, colleagues. My name is Aparna Somanathan. I'm the practice manager for the World Bank's program in health, nutrition, and population in the East Asia Pacific region. And I've had the pleasure of meeting you, Dr. Fong, and several of your colleagues from the Ministry of Health not too long ago in September. I'm really sorry I can't be there now. One of our goals at the World Bank is to ensure that the World Bank's regional and country activities in human development are informed by global strategies while being focused on supporting country-specific challenges. The need to adapt global innovations and ideas to country contexts that you mentioned, Dr. Fong, and the need to build capacity to implement them, particularly in small island contexts, are real priority for us at the World Bank. We see these webinars as a valuable opportunity to start that process through knowledge sharing, adaptation, and implementation. So with that in mind, I'm glad that all of you were able to join the last webinar series the last of the webinar series on our region's key knowledge exchange activities today. We'd like to thank the Ministry of Economy and Finance of the Republic of Korea for their support in this endeavor, as well as all participating countries. What we've learned from countries is the importance of incorporating lessons learned from previous experiences. Many countries in the East Asia Pacific region suffered from infectious diseases such as SARS, MERS, Zika, and influenza A viruses. And they were also at the forefront of the impact of COVID-19 in early 2020. However, the region has cleverly turned the misfortunes to their advantage and effectively controls the transmission in many instances. Korea's response, which relied more on social distancing than stringent lockdown measures, leveraged the legal bases and institutional infrastructure that were developed from the successes and failures of the previous outbreaks, which facilitated communications and mobilization of resources. As in Korea, the previous outbreaks that hit the region provided a solid foundation for the early response. The case of Mongolia also highlights a series of interventions that improved over time along the paths of the pandemic. In Malaysia, the frequent communication between multilateral partners and with the public helped prompt engagement and public participation and build trust through transparency, which in turn supported swift responses. In our region, Mongolia, Malaysia, and Fiji closed borders early, often defying the advice of international health institutions. And the experience from Fiji underscores the importance of the proactive, stringent measures taken by government in the early stage and the decentralized delivery of services in the later stage. Vietnam's unique features in response, such as community-based prevention campaigns and monitoring schemes, increased stakeholder engagement, and the mobile medical stations expedited testing and treatment. So the experiences of these countries commonly call attention to the importance of universal health coverage and the use of ICT in all aspects of the pandemic response. Unfortunately, we know that COVID will not be the last pandemic. The risk of future pandemics is increasing with environmental degradation, rapid urbanization, and international trade and travel. And as Dr. Jamesa very correctly pointed out, countries like Fiji are battling not only the risk of future pandemics, but the even greater risk of climate change events that then elevate the vulnerabilities to disease. So at the World Bank, we are fully aligned with supporting countries for the long term to build resilient health systems that will prevent, prepare, and respond to future pandemics, as well as work multisectorally to restore and build human capital globally. So with that in mind, I would like to thank the speakers and experts who have collaborated with us on this project, and I look forward to hearing about the key themes of the pandemic preparedness and responses in March. I hope this informative session will strengthen our understanding of pandemic responses and help us to better prepare for the future pandemic, not least in the South Pacific. Thank you.
Thank you very much, Aparna. And thank you, Margareta, for that, leading the moderating session for the panel discussions. Now I'd like to introduce Jason Alford, Special Representative and Country Manager for the World Bank Korea Office, to deliver the closing remarks. Jason, the floor is yours.
Thank you very much, Kevin. Nisa Bulavanaka, annyeonghaseyo to everyone. First, I'd like to start out by thanking everyone who's joined us today. Secretary Fong, we really appreciate your hosting this event, and I know whenever I've spent time with Fijian public servants, your phones buzz continually with more work to do. So we're very grateful for the time that you've spent with us this morning. Dr. Waka, I know you stepped in at the last minute to deliver your presentation, and it was truly excellent. So thank you very much for doing that. Also to my colleagues here in Korea, Dr. Lee, Dr. Kwon, we appreciate very much your participation. And then, of course, to my World Bank colleagues, Aparna, Margareta, and especially to Vikram and Kevin and the team, thank you very much for carrying out this work and delivering these great webinars and presentations. And then, of course, to the technical staff here in Korea and also there in Fiji, thank you. You've delivered a great presentation with no problems, and even when Vikram didn't turn his microphone on, I could still hear him here from Korea, so no problems there either. I'd like to join Aparna in saying, this has been really valuable work. I think even though a lot of people would rather move on and not think about COVID anymore, and we are perhaps moving to a stage where it becomes endemic, as health professionals know, we still need to do the work to understand what happened, where our responses were successful and where they didn't work so well. And Dr. Waka made the point that the next pandemic will come sometime, and we need knowledge from this one to deal with the next one. I think again, I'd like to join with Aparna to thank the Government of Korea for funding this work. And I think, for me, a really valuable aspect of the work that's been done here is this cross-country comparison. So looking at the 5 countries, Korea, Mongolia, Malaysia, Fiji and Vietnam, and looking for those points of commonality in the response and differences, and where we have commonalities in the successes and failures. And that has been really great work, and we really appreciate that both Fiji and Korea have been very open with us on what has worked and what hasn't worked so well. Our office here in Korea, we focus a lot on the technology side of development solutions. And again, this work has focused on that of where we've been able to apply new technologies to respond to COVID. So let me finish there. Thank you all again. Thanks to the audience for joining us. So Vinaka Vakalevu, thank you all so much for your work and joining us today. Thanks, Kevin.
Thank you very much, Jason, for your kind remarks and delivering this at a very early hour in Korea right now. Now I'd like to wrap up today's webinar. On behalf of the World Bank, I would like to express my sincere gratitude to all the speakers and presenters online and for the participants who are here live in Suva. All the recordings of this webinar series will be available in the link that I will share later on. And we will also find a short feedback survey within the link that I will share. So we'd appreciate any comments or follow-up questions that you may have, and we'll try to address them as best as possible. Now, also please stay tuned for more information on our project's regional COVID-19 preparedness and response forums, which will be held in May of 2023, and we'll share more information through different kinds of channels early next year. Thank you again for all those who have participated from all around the world, and I hope you have a great day or a good evening. Thank you so much. you.